Alrighty, I think we're in business. Well, thanks everyone for having me, Dr. Dumovic. I had the pleasure of speaking at the last NMO Patient Day, and it's great to be back. This time I'm speaking in at a pretty narrow topic with pregnancy and breastfeeding, but you've already heard this morning just how much these presentations of both NMO and MOGAD, as well as the presentation of transverse myelitis, all tend to have a preferential effect on young women that are primarily of childbearing age. And so a lot of the treatment decisions that we are making have to be considerate of how this might impact someone's personal family planning goals, and then what to do postpartum. And that's what I'm hoping to cover today. It's a big topic. We'll try to do as much as possible, but I'm happy to set the foundation in these next 30 minutes and then answer more in the Q&A. My main disclosure here is that there are off-label use of medications that will be discussed just by nature of how our package inserts in the FDA label our medications. I will tell you that when I discuss it. But our overview today is just to provide a background on what we know, to think about the disease-specific considerations within NMO, MOGAD, and transverse myelitis, and then how those considerations might be applied throughout the spectrum of pre-pregnancy, during pregnancy, and then postpartum in the setting of breastfeeding. Why? Well, as a neurologist who practices down the street at Duke, I've been caring for patients with neuroimmunologic diseases since about 2017. I met a patient in 2020 who came to me with a pre-existing diagnosis of MOGAD and a decades-long history of recurrent optic neuritis. She had been stable on treatment with infusion therapy for about 2 years before she saw me and had moved to the area. And during her first visit with me, she said, "I'd really like to grow my family. I've been dealing with this disease for as long as you've seen in my records for decades. And now that I'm not having recurrent optic neuritis affecting me on an almost yearly basis, I think I'm at a place that I'd like to grow the family that I'd always dreamed of having." So that's our foundation for how we're going to think through the data in the next couple slides. As we've already heard a lot of our foundational knowledge rests on demyelinating disease, the most common of which is multiple sclerosis. And this is just a snapshot from our literature database, PubMed, and how many publications come out on an annual basis going back as far as 1901. And you can see this exponential growth that's happened since 1901 to the last decade or so, where we have about 900 publications a year. Remember this slide. In the MS world, we have tons of therapies, going over 27 plus at this point, with lots of reiterations with generics available to us. And they all come in various forms. So that 900 number of publications per year makes sense. We've got a lot of treatment options. We really need to consider them for this disease that affects 2/3 up to 3/4 of the patients affected are women. And it's led to lots of prospective studies, robust studies going back as far as 1998 on the incidence and the effect of pregnancy on MS. For example, this one from 1998 showed that the relapse rate in pregnancy, that's the gray box, goes down for patients with MS when compared to prior to pregnancy. Let's see if I've got a pointer here. Y'all can't see that. Let's see here. There we go. So straight line here before pregnancy. The gray shaded box is during pregnancy, relapse rate goes down, and then that scary spike postpartum is how MS tends to relapse postpartum. I don't have graphs like this that have been done in such a robust way in NMO, MOGAD, or transverse myelitis. And fast forward to 2021, we were able to replicate that data in the MS world. So this is what we know currently. As providers who care for patients who have demyelinating conditions, we recommend that there is ideally a disease-free, relapse-free state prior to pregnancy of about 1 year. And once that 1 year cutoff has been met, then we can start to consider pregnancy planning. If there is active relapsing disease before pregnancy, that is a risk factor for post-pregnancy relapses. Makes sense. If someone was super active before, they're likely to stay active through and after. And all patients should be advised on contraceptive use, specifically with certain immunosuppressive or immunomodulatory therapies. And those recommendations, based on the label, based on what we know scientifically, vary from several weeks to several months, as it says on this slide, up to a year, depending on what we're discussing. This is what we know about NMO. So you can see when I went to 1900 onwards, the earliest publication we have on pregnancy and NMO is 2012. And on average, somewhere between 10 to 15 publications per year in this last 13 years. In MOGAD, it's even less. The earliest publication we have on just pregnancy and MOGAD is back to 2021, and anywhere between 4 to 6 publications per year. So suffice it to say, we don't know enough to really make robust recommendations. And what we do is gather consensus guidelines amongst experts who really are passionate about understanding women's health and how it affects our neuroimmunologic diseases. Finally, transverse myelitis, as you heard from Dr. Diaz, has been around for a while. It's a description of a presentation. And for that reason, we do have a lot more lengthier of a timeline of how much we've published on pregnancy and transverse myelitis. And it tends to vary, but again, in the last decade or so, there seemed to be more interest and more focus in the scientific literature of learning about it. I'm going to give you in the next few slides just a little bit, it's going to seem like a lot of words, but I promise I'll explain us through it, a lot of background on what we know, and I'm going to start to set the stage about what we know about monoclonal antibodies and pregnancy. Why do I do that? Well, in a lot of our treatments for both NMO and MOGAD, you'll recognize that the medications end in MAB, that's monoclonal antibody. And we know that all of the treatments that we use that are monoclonal antibodies, which are not the only treatments for these diseases, are made of IgG proteins. Those are immunoglobulin. And those are the only antibodies that can cross the placenta. So if we're thinking about planning a pregnancy and growing a child in someone who's treated with these conditions, we have to think about them very, very in a lot of detail. We know that if someone is exposed, this is based on monkey studies, but also very old 1990s studies based on people who were treated with monoclonal antibodies in the setting of cancer, like rituximab, that baby concentrations, fetal concentrations of these monoclonal antibodies steadily increase throughout pregnancy, and the amount that's in mom is the same as in baby at about 26 weeks. We also know that because of the development of baby and placenta, the ability to take these very large proteins and transfer them into the placenta, we call it transplacental transfer, really cannot occur until after about 16 weeks of pregnancy. We'll remember that, and I'll come back to it in a few minutes, because that helps me perform some reasonably sound math to help us direct how to guide care with some of our monoclonal antibodies. And then we also know that the maximum cross-placental transfer occurs in the last 4 weeks of gestation. So if someone needs to be treated with any of these class of medications in the last 4 weeks of pregnancy, baby's getting everything. What we also know, and this is very much borrowed from the multiple sclerosis literature, is that if there are new neurologic symptoms in the setting of pregnancy, we can do a few things. We can get an MRI, though we don't recommend giving gadolinium contrast in the setting of pregnancy. And if there is a relapse confirmed, both either from seeing the person, the patient who's living with the disease, or from the MRI changes, then there can be a consideration for treatment similar to what you've already heard about this morning. Steroids are the first line. They are considered by the American College of Obstetrics and Gynecology, ACOG here, as safe when considering the risks and the benefits. And so if someone has, you can see back here, a loss of function, those are those last 3 words on this slide, can't see, can't walk, which a lot of our diseases really affect that we're talking about here today, then it is reasonable to consider treatment with high-dose steroids to help reduce the amount of time that the person living with the disease has to feel that way, to help them get better sooner, and particularly when we're considering all of this in the setting of pregnancy, allow them to continue to stay healthy and grow a healthy baby. The main risks that have been associated with steroids in the setting of pregnancy are things like hypertension, preeclampsia. There's also been reports of low birth weight. And so all of these considerations have to be made in conjunction with the OB team, or often, in our case, a maternal fetal medicine specialist, which are the high-risk obstetricians, high-risk OB specialists that collaborate with us as the neurology team to think through, are these risks worth the benefits, all while having that conversation with the person living with the disease. There's a couple different types of steroids that are preferred by both the neurologist consensus guidelines as well as the obstetricians and gynecologists who provide these recommendations. The big no-no is dexamethasone, which is a type of steroid that's available IV and by pills. because that almost all of it, 80%, goes straight to baby. And we'd rather not treat baby with steroids if we don't have to. We think that could affect bone growth. So, as we mentioned, this graph, I don't have it. I don't have a replication of it with prospective data, meaning people who joined a study when they became pregnant or as they were planning on it, or followed through both pre-pregnancy, during pregnancy, and post-pregnancy for patients with neuromyelitis optica, TM, or MOGAD. And I think that's a big potential for research in the future. But in general, it is not recommended to treat patients who have had any of these diseases, who carry that diagnosis, with steroids postpartum to help cool down disease, though it's a really common practice. I was just on a specialty call in May of this year where a colleague of mine from the Western US, who's well known and published in the autoimmune neurology world, shared with me that that's her practice. And I shared with her that there's really not much science to guide it, but there's of course a lot of conservative management of we don't want to potentially miss an opportunity to treat. And so you might hear different things as you think through pregnancy planning and postpartum planning in the setting of these diseases. And I think what my guidance would be to all of you is to question what's that based out of, and do we really have science to show it's going to do good? Because truthfully, no medication is without risk. What I'll do in the next few minutes is go through what we know about these specific conditions, with the major disclaimer that there's a lot of limited data here. But all of these diagnoses, especially NMO spectrum disorder, is considered a high-risk pregnancy, which means from the get-go, just like Dr. Diaz just mentioned, we really invite and encourage multidisciplinary care. We want other team members, other clinicians to be part of those conversations so that there can be a thoughtful back and forth to inform our patients of how to best determine how to go forward with their care. So for NMO in pregnancy, we know a fair amount. As you saw, that the data is most present relative to MOGAD in NMO going all the way back to 2012. I'll start with fertility, right? When we talk about planning pregnancy, we have to start before pregnancy and think about how and when and if that may happen. We do have a report of infertility in about 6% of patients with NMO spectrum disorder that are female back in 2017. So again, slightly older data, but we have this report that this might be present. Now that number is pretty similar to what we see in the general population these days, but there's a lot of underreporting in that world, particularly for when it comes to scientific publications. And about 13%, so 1 in every 6 patients with NMO spectrum disorder reported a delay achievement of pregnancy by greater than a year. In the medical world, that constitutes a diagnosis of infertility, where there's been at least 12 months of trying. I'm going to shift that diagnosis a little bit, particularly when it comes to the conditions we're talking about today, but you can see there that maybe up to 13% of patients with NMO have reported infertility that meets criteria. The considerations to think about in NMO specifically is our patients are typically older at the time of diagnosis. We think about MS as our comparison to primarily affect young women 20 to 40 years old. In our epidemiology or in our understanding of how NMO spectrum disorder presents, still a much stronger prevalence of women to men, but the median age of diagnosis is about 40, so it's slightly later in life. And there might be some age effects on that. Just as a woman who is living on this earth, there's lower eggs, that's the oocyte count, just with every year that goes by. We also know that aquaporin 4, which is what the antibody is in NMO, what it targets, those aquaporin 4 channels are expressed highly in the hypothalamus. That is a key regulator of sex hormones. And so if there's a dysregulation there because of the target of aquaporin 4 antibodies, that might affect the ability to achieve pregnancy or maintain fertility. We've got some mice studies. I will fully acknowledge mice are not humans, but it's where we often start with our understanding of these diseases. And in mice that all of their aquaporin 4 channels were knocked out, they were found to have reduced estrogen and progesterone levels. So again, there's an implication there that there's more to NMO than just the optic neuritis, the transverse myelitis, the degree of neurologic change we see, There might also be a tenfold upregulation of aquaporin-4 that we've seen again in mice during pregnancy. So we know that aquaporin channels go up in the setting of pregnancy, at least in these mice. We don't have the same studies in humans yet. Couple things, again, probably a lot more like foundation setting here, but happy to answer questions about this during the Q&A, is that we know that in patients with NMO spectrum disorder, the amount of anti-Müllerian hormone is lower, which means that that is a sign of ovarian reserve. So anti-Müllerian hormone goes down with age, and in NMO, when you're matching it to someone without NMO of the same age, those numbers are lower. So again, there might be some impacts on fertility there, hormonally. And then finally, you've already heard some of the medications we use in these diseases, but in NMO, things like cyclophosphamide or methotrexate independently can impact ovarian reserve and sperm count. And that can also result in impaired fertility for both men and women who have been treated with these medications in the setting of NMO. So then how do we think about that? Let's say we've made it through all of that, we've partnered with our colleagues, we've talked to MFM, we've even reached out to a fertility specialist to assist our patients to get the best care they can to help achieve their goals of growing their family. Well, a couple things to know here. Unlike what we've seen in that gray box in that study that I keep referencing in the multiple sclerosis world, we know that NMO activity can increase in pregnancy. And that is a major deviation to how we practice for our most common demyelinating conditions, MS. Unlike MS, pregnancy is not protective. There's lots of reasons to this. I've written one in the bullet here. There's some shifts between specific immune helper cells called Tregs and Th1, but basically this idea that the shift in the immune system during pregnancy actually favors the kind of immune system involvement that NMO needs. That shifts away from the kind of immune system involvement that MS needs. So it protects against MS, but it actually promotes inflammation that we see in NMO. And again, that speaks to the fact that they're very different diseases, even though on pictures and how we see it in patients, sometimes it looks similar, though not exactly. A couple things to also understand about NMO. We do know that there has been a reported increase in miscarriages, 43%, prior to disease onset in the same population, meaning after the diagnosis of NMO, patients with NMO were noted to have miscarriages, and if you're comparing their pregnancies prior to pregnancies post-NMO, that number goes up. The average population miscarriage rate is about, it's underreported again, but 15 to 20% is what we say in the medical literature. So this is near twofold. It's something worth considering as we think about achieving a successful pregnancy, of whether or not that may happen and how to better educate our patients about that risk. There have been reported increases in intrauterine growth restriction and an increased risk of preeclampsia and eclampsia, which are pregnancy complications, again, fourfold to that of the general population, 12% in patients with NMO versus 3% in the general population. So we're seeing enough indications to tell us, there's something about NMO spectrum disorder specifically that makes for a perhaps more challenging pathway to a successful pregnancy. And we'll talk about how we try to address some of that. A couple other just kind of factoids here. We know, again, this is supporting a lot of what I've already said, which is that aquaporin-4 channels, these aquaporin channels do shift, and they exist in the placenta in the setting of pregnancy. And now if you've got aquaporin-4 antibodies floating around, you have the potential for having these antibodies go and attack the placenta, which may cause that increased risk of miscarriages we're seeing. Finally, we've talked about this a little bit, the relapse risk is higher during pregnancy and postpartum, but we found a couple things in our reporting that can be signs of whether that might happen. One, in the year before pregnancy, if there's more relapses, that's a higher indication of during pregnancy having relapses. Sort of makes sense. It means that the disease has still opportunity to get better treated. Two, if someone is stopping their immunosuppressive therapy before or during pregnancy, well, then they're undertreated, and we've already talked about how pregnancy shifts them towards more relapses. So stopping therapy might actually get in the way of having a successful pregnancy, or may also encourage more relapses. Also seems to make sense. For some reason, it does seem to be that if someone has a younger age at the disease onset, they are more likely to have pregnancy-related relapses. And then those titers of aquaporin 4 antibodies, if they are higher at the onset, not necessarily through pregnancy, but at the onset, at the diagnosis, those have been associated with more complicated pregnancies with more relapses. And of course, as I've encountered in many of my patients who are considering growing their family in the setting of NMO, there's the question of, well, what does this mean for my child, for my future child? Well, we know that NMO spectrum disorder is familial in about 3% of affected folks. That means that 97% of folks don't have any genetic predisposition or passing on to the next generation. We also know that those aquaporin 4 antibodies, we talked about antibodies tend to cross through the placenta later in pregnancy. So in the second and third trimesters, that happens most. And we have been able to test aquaporin 4 antibodies in infants born to moms with NMO spectrum disorder for the first 3 months postpartum, and then no disease, so no manifestations of relapses in baby, and those antibodies sort of peter out over time. And at the 2-year mark, we can't measure them in baby. So yes, it passes, but no, it doesn't cause damage. These next 2 slides are a whirlwind, I'm going to warn you, but the goal here is for you to have a summary and a sense of what we know about the medications that we use in NMO spectrum disorder, particularly as it relates to pregnancy. The main takeaways are, this is my editorial, I don't really love the small molecules, the pills, the azathioprine, mycophenolate mofetil, and methotrexate. Why? They're small molecules. So that 16-week rule that I told you about monoclonal antibodies, that goes out the door. Baby's getting these medications as soon as baby is developing. But because of the history and the timeline of use of azathioprine and mycophenolate mofetil, we do know from other conditions, particularly rheumatoid arthritis, post-transplant patients, that both the azathioprine and mycophenolate mofetil have timelines of whether they could be continued or should be discontinued, like you see in the MFF, which is CellCept, if you've heard that before. The very bottom line, though, the methotrexate, we know it's teratogenic even at low doses. And so there are patients who have been treated long-term with methotrexate, and if there's a consideration of pregnancy, it's usually a good time to think about switching therapy to set them up for success, to carry a successful pregnancy without harming baby. You've already heard those monoclonal antibody, my disclaimer. I've got a list of a couple of them here, but in general, we've got a lot of accumulated data that tends to support safety. I'm going to skip to, let's try 2 slides later. I don't know how much you can see it, but there's a couple items on this slide that I'd like to point out. This is a consensus from the French French MS and NMO Society that guided how pregnancy planning should occur in best practice. And what you'll notice at the very top of the chart is that there is a consideration of half-life, which is how long a drug lasts before 50% of it is gone out of the circulation. There's a consideration of what the label says, that's the 3rd column, and then a consideration of when you should actually discontinue it. And so when I talked about my off-label use discussion, this is it. I'm not necessarily recommending any specific medication. I'm sharing that what the label says, the consensus guidelines amongst experts in the women's health and neuroimmunology world and the NMO, MOGAD, TM world is different. And that's because of math. What we typically say in the medical world is that it takes 5 half-lives before medication is about 99% or greater out of the bloodstream. And you can see here the medications, the MABs on this page, have variable half-lives. As low as 5 days for tocilizumab, and then up to like 20 to 30 days for some of the B-cell depleting medications. If we time out 5 half-lives, for some of them, like the tocilizumab, that's 25 days. That's a month and the med's out of circulation, which is why it makes sense the med's given on an every month basis. For the rituximab or inebilizumab, if it's on the 18 to 20 day range, 5 half-lives puts you at 100 days. I'm going to review back to something I mentioned earlier, which is that these monoclonal antibodies do not cross the placenta until about 16 weeks of gestational age. 16 times 7, that's about 112 days. And so there is enough science to say if you wait, look at that 4th column, if you wait somewhere around a month for most of these, you're giving yourself, even then, a conservative measure of an extra 30 days before whatever's circulating actually makes it to baby. And a lot of our guidelines on how to think through growing your family and planning a pregnancy are based off of that. With delivery, the big kind of superimposing argument is that there's no specific type of delivery that's recommended in our world. We don't have any higher risk of adverse events after anesthesia, and there used to be a time where many of my anesthesia and OB colleagues would say, every one of your patients needs a C-section. It's not true. You have to do what's right for mom and baby together. But we have to consider each person individually. There's just no blanket statement. So delivery method, analgesia, the recommendations from our perspective as neurologists is you do the same as what we do in MS in the general population, but you take it person by person. And then postpartum considerations, the main things I'll mention here is that if baby has exposure in the setting of pregnancy to B-cell, particularly in that last couple trimesters, second and third, we know baby's been exposed to that B-cell depleting medication. It's a medication that takes away one part of your immune system, your B cells, which create antibodies. And so because of that, as baby is going through their vaccination cycle, particularly live vaccines, we delay those vaccines by 6 months because there can be a risk to harm to baby and a risk to not develop a vaccine response. So you might be giving baby something that they aren't able to mount a vaccine response to. And that does, again, require good conversations, good communication between you as the patient, your provider team, including your pediatrician now for baby. We also know that in the NMO population, using Rituxan, old data, within a time frame of about 2 weeks, reduces the risk of relapse by 10%. And all this helps us echo is that early reinitiation postpartum may help continue to prevent relapses. My quick words on MOGAD and pregnancy are the following. One, with MOGAD, y'all probably heard about earlier, we're sort of still figuring it out. I heard the tail end of making decisions on whether someone has relapsing disease before deciding to put them on treatment. And in addition to everything we learned about rituximab with NMO, I'll also add on that many of my obstetric colleagues use IVIG for various indications in the setting of pregnancy. So if someone has relapsing disease, bad enough that IVIG was the only thing that controlled it, then it's possible to continue IVIG through pregnancy, though it may not be needed. Some of our more recent studies reflect that MOGAD may act kind of like MS, where pregnancy is a protective state, which means we don't often have to potentially risk baby to an immunosuppressive therapy if we don't absolutely have to. And then as y'all probably heard too, MOGAD doesn't always require long-term treatment. And so again, the goal is to do the best for the patient living with a disease without over-treating. And finally, my last word on transverse myelitis and pregnancy is the following. With transverse myelitis, what we're often managing are our symptomatic concerns. And of course, you're going to hear a lot about that later today. But from a family planning consideration, the main thing to consider is less about maintenance medications and more about how do we help support someone physically through the act of labor. And spasticity can get in our way, pain can get in our way, and ensuring that those conversations are had with the OB team, with an MFM team, so that things like baclofen or gabapentin or the medications that we're using for management of the symptoms related to TM are being considered and not just stopped cold turkey in the setting of becoming pregnant or wanting to become pregnant. So in our last few minutes, I'll end with just a general overview of how we like to approach treatment, which is with the simple question of, are you planning on growing your family in the next few years? Huge caveat here. About a third of pregnancies are unplanned. The number's been higher in some reports too. And so all that said, it's good to at least think through with our teams in the room whether there might be a consideration of actively planning, knowing that life can happen and there can be unplanned pregnancies. This is a lovely algorithm that was shared in one of our recent publications, which is a review article for clinicians who are caring for people with MS and NMO. And you'll see here it says, if there is a patient with MS or NMO of reproductive potential, right, have not become menopausal yet or haven't had a hysterectomy for another reason or for their own indications yet, then that's kind of the algorithm. Do you think through with the patient in the room, are you ready to grow your family or are you not considering it right now? And if that conversation is happening early in the time of diagnosis, and often you can allow sort of this reset of, are we on the right meds for this, or do we need to think through what alternatives would look like in order to support a successful pregnancy for mom and for baby? We mentioned a little bit about fertility, but the other piece I'll mention is many of the conditions we've talked about today. I know Dr. Diaz just mentioned on the right side, there are frequent comorbid disorders, autoimmune thyroid conditions, lupus, antiphospholipid syndrome. These are all conditions that if we know they are co-occurring with NMO especially, or MOGAD, or transverse myelitis, they have to be taken into consideration. Many of these require blood thinners or aspirin because of their risk of clotting, which then can threaten a successful pregnancy too. And then we are actively engaging in a longitudinal study to look at fertility treatments and their effects on MS and NMO starting soon. Last bit, and then I'll stop, which is breastfeeding. Similar to what you heard me mention about transplacental transfer, the quick summary is the larger the molecule, like our monoclonal antibodies, the less likely it is for the treatment to pass from mom's gut or from mom's IV bloodstream to the breast milk, to baby, to be absorbed through baby's gut and actually have a meaningful effect. We call it a relative infant dose. And all that said, our consensus guidelines, those same tables that we have, similarly say that our medications like rituximab can be used safely in the setting of breastfeeding, but need to have a conversation about that. And that relative infant dose is a conversation we consider there too. Those small molecules, they pass on through. So they're right in the breast milk, they'll go right to baby, they'll get absorbed by baby's gut. So again, something to consider there too. We're really trying to get away in the women's health world from this phrase of pump and dump. It's cute, it rhymes, it doesn't actually need to happen. And I've seen and personally experienced how hard you have to work to be able to breastfeed. And so all that said, I really do try to partner with my patients to ensure that they are equipped with the right tools to be able to know what meds they're on and whether they need to dump their breast milk. And there's a great website called LactMed, which helps us better negotiate that. It's kept up by the FDA, and it's an update on all of the scientific literature. So in recent weeks, it may not be quite as kept up, but overall on a yearly basis, it does a good job of keeping us up to date on what we know about certain meds and their ability to be used in the setting of breastfeeding. So how did the patient I talked about do? She did great. She was kept on her medication. She did the 2-month timeline where she'd received her dosing of her infusion therapy. It was a once every 6-month therapy. She started trying to conceive, and luckily enough, because truly there's not a whole lot more than that, she became pregnant within a couple months of trying to conceive. And she was able to stay off therapy for her MOGAD through pregnancy, start back immediately within a week or two after with the same medication, do the same thing all over again. She has 3 healthy babies. She's got a very busy life, but she was able to get to her dream of wanting to grow her family. So shared decision-making is the ending statement, which is this is a conversation that has to be iterative, that has to be revisited in order for us to do what's best for everyone in the room, including any future offspring. And looking at how active someone is before pregnancy is a really good way to gauge whether they might be physically ready from a disease and relapse perspective to consider growing their family. With that, I'll end there. Thank you all for having me.